Good morning, good afternoon, good evening, buenos dias, bonjour. On behalf of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology, Indian Academy of Neurology, and Forum for Indian Neurology Education, I welcome you all for this session of WFN Neuro Infection Series 2. Today we have a very unique and different session. And to chair this session, we have Professor Ashok Pangaria. Is one of the leading clinical neurologists in the country. The multifaceted personality with great blend of academics, research, leadership, administrative qualities, and huge philanthropic outlook. Dr. Pangaria published about more than 100 research papers. He had a chapter on parasitic infections of the nervous system in Bradley's textbook of clinical neurology. On an administrative side, he has been a Vice Chancellor of the Rajasthan University of Health Sciences, member of State Planning Commission, advisor to the government of Rajasthan on health and medical education, advisor to Central Council of Health, Government of India, associate editor, Yearbook of Neurology and Neurosurgery from 2007 to 2013, and is a past president of Indian Academy of Neurology. He received various awards, and the distinguished award was Dr. B.C. Rai Award for being an excellent teacher, and he received Padma Shri in 2014, which is a great honor given by the President of India to selected few. Welcome, Dr. Ashok Pangaria, a very good friend. We also have Professor Vivek Lal, who is Professor and Head of Neurology at PGIMER Chandigarh. He is a former Dean, Baba Farid University of Health Sciences, Punjab. He was invited chair and faculty, teaching course and scientific session on neuro-ophthalmology at the World Congress in Dubai in 2019, World Congress of Neurology in Kyoto, Japan in 2017. He's a very popular teacher and most sought after faculty, not only in India, but in other countries also. He has been a visiting guest faculty in neurology, University of Oxford, UK, teaching faculty, Medical Ophthalmology Society, UK again in 2016, visiting neuro-ophthalmologist, University of Addis Ababa, Ethiopia. And he had a very seminal work in the identification and discovery of ophthalmoplegic migraine. For the first time, it was published in 2009. And he has a single largest series in the world literature on ophthalmoplegic migraine. Had more than 200 publications, book chapters, and edited books. The first series of this WFN neuroinfection series was dedicated to Professor J.S. Chopra, and I am happy to mention that today both the chairs, Dr. Pangaria and Dr. Vivek Lal, are students of Professor J.S. Chopra. Welcome, Professor Lal. I would also like to welcome Professor Heidi Haro Mizusawa, who is an invited panelist. He is the president of National Center for Neurology and Psychiatry since 2016. Director General, National Center Hospital of the Institute from 2014 to 16. He did his MD in 1976 from Faculty of Medicine, Tokyo University. And then he was awarded PhD at the same place in 1983. He moved to Tsukuba University as assistant professor and then became associate professor in the neurology department. And he had other distinguished positions. He's chair of WFN nomination committee. He served as president of Japanese Society of Neurology from 2010 to 2014 and president of Japanese Society of Neuro Infections from 2008 to 2016. He was president of PRIAN 2016 in Tokyo, and we always remember a wonderful WCN he organized in 2017 in Kyoto. Welcome, Professor Mizu-san. In the room, we have Professor Raj Shakir, former WFN president, Professor B.S. Singhal, who is Director of Neurosciences at Bombay Hospital, Professor S.M. Kathrak, and Dr. Augustina Charve-Feli, who is the President-elect of AFAN, Christina Vara, Hadi Banji. And I would also like to welcome today's speakers, Dr. Ashish Atrey and Dr. Radotra. And we are waiting for, I think, Professor Joe Berger will soon join. And warm welcome to all the audience. Now, today's session is the sixth session in this series. And next Saturday, we'll have a session on neurology of HIV. And on 12th, we have a session on pyogenic meningitis and brain abscess. So that will be the end of series 2. But in 2021, we'll meet less frequently. So we'll start with a new session on first week of the first Saturday of the month, that is in February. We'll have a talk of the month. It will be a kind of, meet the professor kind of situation, and the case of the month. So it will be not a 2-hour session, but it will be 1.5 hour session. So that we'll have from February onwards, one session in a month. So we look forward to this very interesting session, and I hope you will enjoy it. And now I hand over, carry on the further proceedings to Professor Ashok Pangare and Dr. Vivek Lal. Thank you very much. Dr. Pangaria. I think you're Dr. Pangaria. Yeah.
Chandrasekhar, the innovative neurologist of India. He has always been doing things, whether academic or clinical, in his own way, and he has made a big mark. It is indeed a pleasure to be with him this evening, along with, of course, I see a lot of my gurus, Dr. Singhal, Dr. Kathrak, and many more. And Dr. Vivek Lal, it is always a pleasure to see this young, smiling, brilliant neuro-ophthalmologist who made his mark at the international level and actually made India proud. It is my pleasure to introduce Dr. Ashish Atrey, who would be the first one to talk on this wonderful academic session this evening. Dr. Atrey is a very, very eminent neuroradiologist who was a founder member of Radiology Society of India. He is also a consultant to BJ Medical College and Ruby Hall Clinic, and we often actually hear him across India on his collections on various neurological diseases, but it would be interesting to hear Dr. Ashish Atrey, as I was talking, he's a chief neurologist, Star Imaging Research Center, and a consultant radiologist, Ruby Hall Clinic, and honorary professor to Sassoon General Hospital. May I request Dr. Atrey to start his presentation?
Good evening. Thank you for those kind word of introduction, and good evening to all my friends in India, and good morning and probably a late good evening to the rest of the people all over the world. What we will have to do is, Dr. Bangaria, you will have to stop sharing your, yeah, I guess so, that's fine. And here we go. Okay, so I guess my screen is visible and I'm audible.
Yeah.
Okay, perfect. So we will today look at the imaging of intracranial infections. And at the beginning, I would say that this is one contagion which is doing all these things to us, from infarcts to bleeds to arthritis to transient callosal changes to signal changes in the olfactory bulbs, etc., etc. And there is obviously no marks for guessing this, but the COVID-19. But what we are going to do in next 45 minutes is that, first of all, let me be very clear that we are going to discuss only intracranial infection and not infestations. That means we are not going to discuss the parasitic infection as we call them colloquially. Then we will try and understand the image analysis in a patient who is suffering from an intracranial infection clinically. While doing this, we will be aware that how para-infectious disease processes can sort of masquerade as infection. We will try and see some of the imaging appearances of CNS infections, which are quite typical or diagnostics. We will not discuss COVID in this talk because I feel there is too much already said when there is too little known about it. We will also give it a pass to HIV-associated infection because, as I understand, it is the topic of your next program. While doing all this, we will always remember that surprise is the way of life in radiology and medicine. And to ensure that everybody's brain is clicking or working apart from mine, what we will do is we will start with a quiz, and the answers to this quiz you can type in the chat box and I will declare those as I see them. So here we begin. This is a story of a 15-year-old boy who suffered from fever, which was followed immediately by giddiness and ataxia. I will just describe these images for you. What we are seeing is there is bilateral cerebellar involvement. Both cerebellar hemispheres appear slightly swollen. They are hyperintense on FLAIR and T2. They are diffusion restricted. There is some enhancement of cerebellar sulci, which is seen in some of the cerebellar sulci. Largely, the lesion itself is non-enhancing, and the angiography is essentially looking normal. So this is the first case, a 15-year-old boy who has suffered from fever followed by ataxia. This is a story of a 6-year-old girl who had fever and rash. Few days later, she had acute onset of right-sided weakness. Her MRI showed a left centrum semiovale infarct, as we would expect. And these are her angiography images. So what we see here is that her right ICA, its bifurcation, ACA, MCA all look good. The left ICA is severely narrowed. We see a severe stenosis at the origin of left MCA. The proximal left ICA obviously is looking normal. So this is a focal lesion which is affecting the left MCA in the proximal part. Now, what my question for this quiz is that what is common to both these patients? Are the MRI findings similar? Are the angiographic findings look identical? Or is the etiological agent which is likely to be common? Or there is nothing similar about these two cases and we really are looking at two different cases. I'm trying to put them together. So you can obviously type your answers in the chat box. This is one more quiz that we will put up. This is a 29-year-old post-renal transplant patient who's suffering from fever, altered sensorium, and has lower limb weakness. So these are his images of posterior fossa. What we see is a focal cerebellar lesion in the left cerebellar hemisphere, which is hypointense on T1. It is bright on T2 weighted images. If you look carefully, you also see that there is something different between the two occipital horns of the lateral ventricles that we are seeing. The CSF in this horn is very clear, while here it looks cloudy on these FLAIR images. And also there is this ependymal hyperintensity, which does not look similar on the contralateral side. So there is something abnormal with the ventricular ependyma, the ventricular contents, and there is a focal cerebellar lesion on left side. This is a contrast enhanced scan, and we see that the cerebellar lesion is showing peripheral enhancement, almost like an abscess. We see this enhancement of the ventricular ependyma as well, which is very smooth, and this is not seen on the contralateral side. So this is focal inflammation or enhancement of the ventricular ependyma. Because he had weakness in lower limbs, his spinal MR was done, and there was a long segment hyperintensity, which is affecting the cervical and dorsal cord. And on contrast enhanced scan, there is a ring enhancing focal lesion in the right half of the cord, probably explaining patient's present symptoms of lower limb weakness. Importantly, there was another image in the brain which kind of gives away the diagnosis, what the etiopathological agent of this patient is suffering from, who is a case of post-renal transplant. What this patient has is ventriculoencephalitis, as we saw. He has myelitis. He also has retinitis, which we are seeing as enhancement and thickening of the choroid and retina on the left side. Compare it with the right side. If we combine all these findings together with the history of immunosuppression, that is patient is post-renal transplant, I think the diagnosis should be pretty straightforward, and it is going to be CMV. So these were the cases which the quiz cases which we began with. Now we will see about the intracranial infection, and the commonly encountered infections are these many. We commonly see meningitis, encephalitis, abscess, granulomas, empymas, and osteomyelitis. We will deal with them one by one. Now, commonest infection that any one of us sees is, of course, meningitis. And when a patient with meningitis presents to clinician, I think the most important thing to know is imaging actually necessary for these patients? I feel most of you treat meningitis without doing any imaging. If clinical diagnosis is straightforward, you will do a lumbar puncture, which will show infection and will probably give you a clue to the etiology, and the patient would be treated accordingly. So when is imaging performed in patients with meningitis? One is to, if you are seeing papilloedema and you want to rule out raised intracranial tension or any contraindication to doing a non-guarded lumbar puncture, you will probably do an imaging, a CT scan or an MRI. Second indication would be to evaluate complications of meningitis if patient is not responding to the usual line of antibiotic or antiviral treatment, and also sometimes to assess the source of infection in patients who are presenting with recurrent meningitis. Otherwise, for routine meningitis, hardly any patients are going to come to radiology department for imaging. Now, in meningitis, there is one important sequence that we have learned over the year plays the most important role. We were initially very excited about the FLAIR images and said that whatever looks hyper intense in cortical sulci like this, the usual sulci should look dark like a ventricular CSF. And if we see any hyper intensity in this cortical sulci on FLAIR images, we used to think that this could be infection. Today, we know that this sulcal hyperintensity can be seen in many other conditions apart from infection, which as we know could be supplemental oxygen on which this patient is, or it could be leptomeningeal carcinomatosis, or it could be due to so many other reasons like leptomeningeal collaterals in a venous thrombosis or in luxury perfusion due to following an acute ischemic stroke. So all these conditions can cause sulcal hyperintensity on FLAIR images. That's why if you see or if you do not see sulcal hyperintensity on FLAIR images, if meningitis is a clinical diagnosis or a clinical suspicion, then contrast enhanced MR is absolutely must. And we would see such contrast enhancement on FLAIR images very well if the meninges are inflamed. Now, as I told you many times on plain FLAIR images, the signal abnormality which you would expect to see because patient has meningitis is not seen. It is not even seen on post-contrast Stephen weighted spin echo images. But once you do a post-contrast FLAIR, this enhancement becomes very glaring. Mind you, it does not always indicate that there is infection. It merely indicates inflammation and breach in the blood CSF barrier, and it could be due to any other cause of meningeal inflammation like chemical meningitis. It need not necessarily always be infective meningitis. The complications of meningitis for which patients are evaluated by imaging, of course, one of the common complications is hydrocephalus due to formation of intraventricular webs due to adhesions and leading to obstructive hydrocephalus, or a communicating hydrocephalus as we commonly see due to basal meningitis caused by specific pathogens like tuberculosis. One of the dreaded complications or other pathology that we commonly see as intracranial infection is an abscess. How does it look? It generally looks very bright on T2 and FLAIR images. It is dark or iso-intense on T1. It shows peripheral enhancement like this. There is a lot of surrounding edema and of course the associated mass effect. The enhancement of the wall is generally very thin and uniform, and one of the important things I want to show you on this image is that the enhancement is not always uniform all along the wall of the abscess. The enhancement typically is thicker along the lateral wall of the abscess as compared to the medial wall. That is because the abscess vascularity is derived from the penetrating vessels which go from cortex towards the ventricle. That's why the vascularity of this abscess or the abscess wall is going to be more towards the lateral margin of this abscess rather than on the medial. That's why the medial wall is thinner as compared to the lateral wall. If I were to ask you to choose one more imaging sequence which will make the diagnosis of this lesion to be abscess almost 100%, I'm sure all of you are going to say that it is diffusion weighted MR image, and the diffusion always almost shows the abscess to be bright and dark on ADC maps. And this is basically because of the complex contents of this abscess, presence of macrophages, the pus cells, the fibrin, all this cause restricted movement of the water molecules or restricted diffusion of water molecules, making the abscess look bright on diffusion and dark on ADC maps. The next question comes is, if I see an abscess, can I differentiate on imaging between pyogenic or other etiologies of abscess? And sometimes we can. We should always perform a spectroscopy, which is a low TE or short TE MR spectroscopy to check for presence of these peaks of amino acids like lactate, succinate, etc. If they are present, this is likely to be a pyogenic abscess. Occasionally, we also see these in fungal abscess as well, but we do not generally see this in tubercular abscess. Now, of course, the other differential of an abscess apart from pyogenic abscess is fungal abscess. And the typical imaging which helps us differentiate a fungal abscess from a pyogenic abscess is presence of this intracavitary diffusion restricted nodular projections from the wall of the abscess. These are supposed to have fungal hyphae within them. They do not enhance because there is no body reaction to this projecting fungal hyphae in the cavity. The wall of the abscess enhances like any other abscess would for a pyogenic or tubercular, but this non-enhancing diffusion restricted contents or projections in the abscess cavity is something which is very typical of a fungal abscess, apart from the fact that because of the high ferritin contents of some of these fungi, the abscess wall also tends to be dark on T2 weighted images and shows susceptibility on susceptibility weighted MR images. If the abscess ruptures, which is one of the complications of this intracranial abscess, the rupture is almost always on the medial side. Why is what we saw in the previous image, because the abscess wall on the inner side is thinner as compared to the lateral side. And how we can identify the rupture of an abscess is by looking at the diffusion restricted contents in the dependent part of the ventricular system, as we see here in the occipital horn of the right lateral ventricle. Of course, there's a large conglomerate abscess here, which will be better seen on the contrast enhanced scan. And this abscess has ruptured and has caused ventriculitis and presence of pus in the right lateral ventricle. One more complication is meningitis and associated vasculitis. Now, vasculitis is a very common finding in tubercular meningitis, but is also not so uncommonly seen in pyogenic as well as fungal meningitis. And what we see is that we see the focal narrowing of the artery in the area where there is leptomeningeal enhancement, and there could be associated surrounding inflammation of the brain, and a resultant infarct could also be seen. Now, apart from the meningeal enhancement and the arterial narrowing that we see, sometimes if we look carefully, we see wonderful images because something else is also happening in the brain, as happened with this patient who had sinus infection and who also, because the sinus infection has spread from there into cavernous sinuses and eventually has caused meningitis, has bilateral cavernous sinus thrombosis. Because he has cavernous sinus thrombosis, we are seeing some very interesting findings. Of course, because of the arthritis, which is bilateral and is catching the both intracavernous ICAs with severe narrowing of these vessels, we are seeing a focal area of medial temporal infarct, fair enough. But interestingly, because the cavernous sinuses are now not enhancing, they are thrombosed, what we are seeing is that there is marked thickening of the internal carotid artery wall, which is also enhancing. So this is an arthritis which is caused by the infection. We know that the spread of infection commonly occurs through the vasa vasorum from the meninges and causes this arthritis. So we are seeing the arterial wall inflammation and enhancement, which is not a common thing to see in intracavernous ICAs because generally the surrounding cavernous sinuses enhance brilliantly. So we do not see this arterial wall enhancement. But here, because the patient also has cavernous sinus thrombosis, as was evident by the spread by the presence of thrombus in the superior ophthalmic vein as well, we are seeing this enhancement of the arterial wall, and we also see this associated narrowing of the both intracavernous ICS. Now, evaluation of source of infection in patients with recurrent meningitis is also where imaging plays a big role. This patient has 4 attacks of meningitis. Every time it was pyogenic infection, and every time it was seen that his sphenoid sinus was always full. But because this time his diffusion weighted MR images were more carefully evaluated, we see that there is a sinus empyema in the sphenoid sinus. At the next time, he underwent a functional endoscopic sinus surgery, and this empyema was drained, and thereafter he never suffered from the recurrent pyogenic meningitis. Now, cause of this empyema obviously is not apparent on this MR, but he had, that's why we have to do a CT, and he had a large osteoma which was obstructing the sphenoid sinus or sphenoethmoidal recess, causing obstructive changes in the sphenoid sinus. Sometimes stories can get more interesting. A 12-year-old boy who had 7 attacks of pyogenic meningitis, every time the organism used to be the same. He has also developed obstructive hydrocephalus with periventricular ooze, but because he had so many attacks of meningitis, he every time had undergone an LP, but never underwent a spinal MR till he had his 8th attack. And what do we see on this imaging? His source of infection was a dorsal dermal sinus. He had extensive abscesses in his cauda equina nerve roots and the conus medullaris. Obviously the diagnosis becomes apparent, very apparent, if you do a diffusion MR and you see these multiple abscesses which are showing diffusion restriction. So he never had any lower limb symptoms at all. Of course, he's a small kid, but he always presented with recurrent meningitis, and because his spine was imaged as a protocol for evaluation of recurrent meningitis to find the source of infection, we saw these multiple abscesses in the cauda equina. Now let's move on and see some special infection which the imaging appearances of which can make you think of the etiology or at least suggest the possible diagnosis. And one such infection is Listeria. It is not because of the imaging appearances of this infection that you should think of Listeria, but because of the topographical location of the brain structures that are affected by Listeria. As all of us know, it is the Listeria rhombencephalitis, which is a typical finding. So if we see this meningeal signal abnormality, which is along the basal cistern affecting the pia of brainstem, it could be seen in any meningitis. Any basal meningitis could have similar appearances. But apart from this meningeal signal abnormality, if one sees ring enhancing lesions like these tiny dots that we are seeing in the brainstem, then a combination or a constellation of these findings and presence of meningitis on CSF examination should make radiologists at least suspect that this could be Listeria, because the choice of antibiotic is going to differ, and that's where suggestion of this being Listeria is very important on imaging. Now, Listeria, I made a mistake of misdiagnosing this case because this again, patient has basal meningitis. There are multiple ring enhancing lesion. So obviously, as I told you, one a radiologist should think that this is Listeria. But the atypical finding in this case was this large areas of hemorrhage, and patient was extremely bad. He was semi-comatose. So patient was deteriorating rapidly. He had extensive hemorrhage, and he did not have much of fever or leukocytosis. So I thought this could be an hemorrhagic leukoencephalitis, an autoimmune disease process, which is affecting brainstem, and reported it that way. But this also turned out to be Listeria rhombencephalitis. And this later on in literature, hemorrhagic changes in Listeria encephalitis is rare, but not an undescribed finding. The other infection which can have typical imaging appearances, and we will see it in little bit detail, is tubercular meningitis. Now, nodular enhancement like this is seen in a meningeal disease process, which is very typically seen with tuberculosis. I'm sorry about that. Somebody was disturbing me from my department. We see this enhancement, which is very shaggy, which is a lot, which can be in the cortical sulci or basal cisterns, but typically the enhancement is not smooth as we see in pyogenic meningitis. It is more irregular, more nodular, more shaggy. There can be associated edema as we see around this leptomeningeal enhancement, and this enhancement also can extend along the Furka-Robbins faces as these enhancing dots, as we are seeing in basal ganglia bilaterally in this patient. Now, enhancement, if you see, is affecting more of basal cistern and less of cortical sulci, then you can obviously think that this is more likely to be tubercular meningitis, though as lately we are seeing it that the cortical sulcal enhancement can be very commonly seen in tubercular, and basal cistern enhancement can be seen in pyogenic meningitis as well, especially if there is extensive cranial nerve enhancement associated with it. Now, because there is basal meningeal enhancement is more common with tuberculosis, or basal cistern enhancement is more common, complication, that is the hydrocephalus, is more common with tubercular meningitis than with pyogenic or fungal. Now, occasionally, we see these findings that patient is having this typical enhancement in the cistern, that in this case, it is in the central sulcus and also in the prefrontal sulcus. This enhancement is nodular. It is quite irregular. This on lumbar puncture, the picture was typical of a tubercular meningitis. His sputum was positive for AFB. All the bacteria were, the culture was responsive to streptomycin, rifampicin, as well as ethambutol. He was started on AKT and steroid because he has meningitis apart from the lung tuberculosis. Subsequently, we do a scan 2 weeks later, and we see that this enhancement actually has become more shaggy. There are more enhancing area. The edema has obviously worsened. Now, this is something which we have seen very commonly nowadays, and this is the paradoxical worsening of tuberculosis after starting AKT. We have seen 3 or 4 cases in last 1 year, which is quite a bit for our private practice kind of a setup. And we clearly knew here that all his organisms were responsive to most of the anti-tubercular drugs that we commonly use. And that's why his AKT and steroids were continue. And this is his scan 6 months later, where all the enhancing exudates have completely disappeared. So this is a paradoxical worsening of tuberculosis. We commonly see it, I would not say commonly, but we are not surprised to see it nowadays on imaging. Next way that tuberculosis affect brain is presence of these tuberculomas. We can see them as we used to call this starry sky appearance to the CT scan of neurocysticercosis. But this is another starry sky appearance of tuberculoma on MRI, where we see these multiple rounded tiny nodules scattered in both cerebral hemispheres. The important thing to note is that all these lesions are looking almost identical to one another. What I mean by that is that they are all in the same stage of evolution. Unlike neurocysticercosis, where we would see when there are so many focal lesions present in brain, we would see them in different stages of evolution. Here we see all the lesions to be almost following the similar signal pattern and enhancement, and some of them are dark on T2 weighted images. Mind you, many other granulomas are also dark on T2. So just a granuloma being dark on T2 does not make it a tuberculoma. Important thing to note is that all of them are in the same stage of evolution. Of course, if you have a corroborative finding on CT scan of miliary tuberculosis and a patient responding to anti-tubercular treatment, the diagnosis is foolproof. Now, the closest differential, as I said, to tuberculoma is neurocysticercosis, and the way to differentiate, it's not always that we can differentiate these two conditions, but the way to differentiate, or more sure shot way to differentiate neurocysticercosis from tuberculoma, is identifying this tiny eccentric nodule of neurocysticercosis, or the scolex, that we would see on this high resolution T2 drive images or on a flare image as a focal area of hyperintensity. Once you see this, you're almost certain that this is neurocysticercosis and not tuberculoma. The other thing to look at is the suppression of signal on flare images in the colloid vesicular stage of neurocysticercosis, when it is bright on T2 but dark on the flare images because of the suppression of the fluid intensity signal. One more question that I would answer here as regards the follow-up studies in patients with intracranial tuberculomas is, can we take enhancement as a surrogate marker for activity of tuberculoma, or to make a decision of stopping of anti-tubercular treatment in patient who has suffered from intracranial tuberculoma? I will just address this question by showing you one case, that this is a scan which was done on the first month of 2016, a 24-year-old lady who came with as a known case of intracranial tuberculosis. She was already on AKT for 6 months. We are seeing these multiple enhancing lesions, which are in the same stage of evolution. Probably all are T2 dark. They are dark on the gradient echo images as well, and are all showing ring enhancement like this. Because she was already on AKT for 6 months, we did a CT scan at that time, and all these lesions, or many of them, were already calcified. She was continued on AKT for 1 more year. She came back for a follow-up, now completely asymptomatic, came for a routine follow-up. We continue to see all these lesions in the brain parenchyma, and showing, many of them stopped showing enhancement, but some of them are still showing enhancement. None of them had perilegional edema. The imaging morphology of this lesion, of being them T2 dark and being calcified on subsequent CT scan, continued. This patient has done well for last 4 years and came back for a follow-up just 3 months back, and is having again some of these lesions are still enhancing. The patient is doing well off AKT. So just enhancement of lesion does not serve as a surrogate marker for disease activity. The lesions can continue to enhance for years after they have been inactive. So that is an important question that many neurologists have asked me over years. Abscess, like we once saw before, did not always be pyogenic, as this is a tubercular abscess showing imaging appearances almost similar to what we saw with that pyogenic abscess, but the enhancing rim is quite thick here. And we see this area, the capsule of this abscess is dark, and the contents are also not bright on T2 weighted images. But most importantly, we do a spectroscopy, and unlike those small amino acids peak, we see a large lipid peak in this abscess, telling us that this is likely to be a tubercular abscess. Tubercular abscess, or for that matter, even pyogenic abscess, could traverse all facial boundaries. For example, this patient had a focal area of signal abnormality in the parietal bone. He had abnormal enhancement along the inner as well as outer cortex of the parietal bone. He had a scalp swelling, a scalp abscess, and also has an intracranial enhancing lesion, which is an abscess. This is when this constellation of findings is what we commonly see with Pott's puffy tumor, with a focal abscess in the scalp, but the associated with osteomyelitis of the underlying bone. But here the enhancement is also involving the pachymeninges, the leptomeninges, as well as the brain parenchyma. If you have a diabetic patient who, as in this case, presented with headache, ophthalmoplegia, and she had recurrent meningitis, what we see is affection of the sphenoid sinus and posterior ethmoid air cells, with this extensive enhancement apparent on the post-contrast scan. And we also see involvement of the cavernous sinus, the orbital apex. Her CSF had raised protein. There was low sugar. There were 100 cells, and large number of those were eosinophils. So obviously, one is going to think of fungal infection of the paranasal sinuses with intracranial spread causing fungal meningitis. If you do a CT scan of this patient, you see this extensive destruction of the sinus wall associated with changes of skull base osteomyelitis, which was causing spread to the meninges and meningitis. Let's change gear and look at the encephalitic disease process, that is now affection of the brain parenchyma per se. When we call a patient to be suffering from encephalitis, consciously or subconsciously, we are almost always thinking it to be a viral encephalitis. And that's how we will deal with encephalitic disease process in next 10 or 15 minutes. Now, viral encephalitis could have either acute presentation, which we commonly see. It could be a post-infectious encephalomyelitis. It could be a slow viral infection, as we commonly see with SSP, or it could be a chronic degenerative CNS disease of viral etiology. Sorry. Now, how viruses infect brain? There are various ways. You know more about it than I do, but more important thing for us to remember or know is that certain viruses affect certain brain structures more commonly than others, and this distribution of the affection of brain can sort of make us think of a possible etiology imaging wise, and that is where what I call is as the imaging footprints of viral infection become important. Now, the most common virus affecting brain is herpes simplex. The common imaging findings is temporal lobe affection with lateral temporal structures more involved than the medial temporal. The affection almost always is bilateral. When it is bilateral, it almost always is asymmetric. Now, medial temporal affection, though uncommon, is not very, very unusual. We do occasionally see medial temporal lobe affection. Hemorrhagic changes is also a very well described finding. In fact, presence of subarachnoid hemorrhage could be a finding if you do a CT scan in patient with herpes encephalitis. The other structures that can get involved are basal ganglia, but basal ganglia involvement is almost always because of contiguity with the temporal lobes. Isolated basal ganglia involvement in herpes encephalitis is almost undescribed. Pons is also an important structure which can get involved. To sum it up, what we see is basically temporal lobe affection. We could also get this typical involvement of cingulate gyrus. So temporal plus cingulate gyrus in a patient who is suffering from fever, has meningeal signs, and is acutely sick. If he has a hemorrhagic lesions like this, the diagnosis becomes more obvious. Diffusion weighted MR images help us in picking up the abnormality earlier than the conventional FLAIR or T2 images. And if we have all these findings with affection of lateral temporal lobe more than the medial, bilateral affection which is asymmetrical, a diagnosis of herpes would also always be under consideration. The next encephalitis is Japanese B encephalitis, which is a mosquito borne disease. And the typical imaging findings that we have seen in Japanese encephalitis, the season for which I guess is just over now, is affection of bilateral thalami and basal ganglia with substantia nigra involvement, also commonly seen. We see these lesions to be bright on T2 and FLAIR. Many times diffusion restriction is the only abnormality that I have seen with near normal or very easy to miss kind of a lesion on FLAIR and T2. So looking at diffusion is very important. Now, hemorrhagic changes are occasionally seen, and more importantly, do we see temporal lobe involvement in Japanese encephalitis or not? Now, we could see posterior hippocampal involvement. It has been reported, but when hippocampal lesions are seen, usually thalami, substantia nigra, and basal ganglia are almost always involved. So it is not that you will see isolated temporal lobe, all hippocampal involvement in Japanese B encephalitis. It is the brainstem and the thalamic involvement which predominates. But mind you that the extension could be to involve hippocampus and the temporal lobe. So hippocampal and temporal lobe involvement is not a kind of seen only in herpes. We could see it in other infections as well. The second important thing that I want to draw your attention to is the association of Japanese bee and neurocysticercosis. There are many papers from India as well as China about this, and the co-infection of from these two structures, one is infestation and other with infection, tends to have poor outcome as compared to patients having only one of these two. And this is a literature example. I do not have one. Affection of bilateral thalami, more pronounced on left side, with presence of a tiny neurocysticercosis in the left parietal lobe. Now, when these things happen, that there is a co-infection, the lateralization is to the side where there is maximum number of neurocysticercosis or where there is cyst with edema. Changes of Japanese B encephalitis are more florid on MR and CT as compared when there is also neurocysticercosis present. This finding is more commonly seen with children, and there is a hypothesis of this altered immune status which allows this co-infection to occur. Now, bilateral thalamic affection and brainstem involvement, as we saw, is commonly seen with Japanese B encephalitis, but it is not only in Japanese B encephalitis. As in this patient, we are seeing bilateral thalamic lesion. We also see involvement of the corpus striatum, but there is bilateral cerebellar affection as well. There are multiple areas of susceptibility indicating that there is hemorrhage in this lesion. When we did diffusion, there are almost all-eyed kind of appearance in both thalami, but the other lesions are also diffusion restricted. Now, this turned out to be dengue encephalitis. Now, dengue could have imaging appearances which are quite similar to Japanese B. Now, neurological manifestation were initially thought to be due to encephalopathy, but now we know that neuroinvasion is a known thing, and we do get dengue encephalitis. Now, bilateral hippocampal and temporal lobe affection, mind you, can occasionally be seen, but many times we see findings which are indistinguishable from Japanese B encephalitis, that is bilateral thalamic involvement with diffusion restriction, extensive brainstem involvement, and bilateral cerebellar affection, which can also be sometimes seen. If you see bilateral thalamic involvement with these punctate lesions which are centrally hemorrhagic, then apart from these two conditions which we thought, we should also think of H1N1, and this patient turned out to be H1N1. He had again had this similar appearance to one which we saw with dengue encephalitis, with bilateral cerebellar, brainstem, and thalamic involvement. The lesions were hemorrhagic. So hemorrhagic lesions in a patient who is suffering from brainstem encephalitis has poor specificity because we are seeing them in more than one conditions. Now, just to emphasize that history is also important when we are evaluating patients with encephalitic disease process. This is a case which I have borrowed from Dr. Rahul Kulkarni. Now, this is a patient who was an ex-alcoholic, a 30-year-old man who had fever for 4 days. Which was low grade. Then he had weakness in both lower limbs, which was of 1 day duration. No upper limb or cranial nerve symptom. He had difficulty in voiding, so his spine MR was done, which showed this long segment cord hyperintensity, which was affecting both halves of the cord. There was no enhancement in the cord, but there was mild cord swelling. He was thinking that this is a case of transverse myelitis. He was started on IV methylprednisolone. On second day, he developed breathlessness. He required intubation. On third day, he developed dysarthria, right lateral rectus weakness, and he was drowsy. So his brain MR was done, which showed that there is involvement of dorsal part of the brainstem and also of the colliculi. There was also involvement of the periaqueductal region. So going back to the history, he had a history of dog bite, which was 1 month ago. And his PCR from nape of the neck was positive for rabies virus. Now, rabies virus can also have extensive brainstem and thalamic involvement. There are several case reports describing bilateral striatal affection like this with thalamic involvement. But what we have found is that in 3 or 4 cases that I have seen, I have always seen this dorsal pontine affection with this horizontal kind of sharp anterior margin. In a typical history, I would say that I would suspect at least that this patient could be suffering from rabies encephalitis. Now, enterovirus is also can have almost similar affection of dorsal pons with this horizontal anterior sharp margin, and it is also well described finding in enterovirus. One, if patient has history of arthralgia, rash, fever, and MR scan shows this multiple tiny areas of diffusion restriction scattered in white matter of both cerebral hemispheres with punctate areas of enhancement, chikungunya is going to be our diagnosis. This is one of the typical patterns which has been described. Nowadays, I have seen hardly any patients in last 3 or 4 years, but 7 or 8 years back, this was a classical pattern that we used to see very often. There are other viral infections which have encephalitic presentation, and they have some of the imaging findings like these enhancing nodules, abnormal signal, but they are not typical, and they can be seen in many other conditions as well. We will end with a long-term effect that we'll see of viral infection. I have got 7 minutes left, so I think I will be able to finish in that. This is an 8-year-old girl who was suffering from intractable seizures. She had progressive mental slowing, gradual progression of neurological deterioration, and we have this bilateral symmetrical white matter involvement of both cerebral hemisphere. Her earlier MR was near normal. She has progressed like this in 2 years' time, and she had suffered from measles 7 years ago. So this was a case of subacute sclerosing panencephalitis. One infection that I don't want anybody to miss, and unless we pay a close attention and do a dedicated MR study, I've missed this many times, especially in diabetic patients, is skull-base osteomyelitis. Now, unless you do a fat suppressed image like this, it is very difficult to pick up the signal abnormalities in the clivus. Once you don't pick up this clival signal abnormality and the associated pachymeningeal thickening along the posterior margin of the clivus, you most of the times are not going to end up giving contrast. Once you give contrast, you see that this entire clivus is showing this abnormal enhancement. There is thickening of the pachymeninges along the posterior of the margin of the clivus, and there is some leptomeningitis as well. This patient was also diabetic, so there was a history of basal cranial nerve pulses in this patient, but missing skull-base osteomyelitis is not very uncommon for us radiologists to do. And I will leave you with a thought that surprise is a way of life, and learning through analysis and reading is the way of medicine. And many times one has to just say the images, see the images, listen to the clinical story, and just say at the end of it, oh, it happens. So I will end by showing you one such case. And this was a patient who was 45-year-old lady who presented with fever and altered sensorium. MRI showed these findings of bilateral cerebral affection. She has extensive temporal lobe involvement, predominantly lateral, but there is also hippocampal affection. There was occipitotemporal gyrus involvement. More importantly, she has affection of both thalami, which is not symmetrical, but definitely there. Involvement of frontal lobe, cingulate gyrus, all is there, right? We did not know what this is. Her MR angiogram and venogram was performed, which was normal. Her contrast enhanced scan did not show any enhancement. There was no leptomeningeal enhancement as well. So because there was extensive bilateral thalamic affection, I said this, and there was neocortical involvement, I said this could be a flavivirus encephalitis. Her LP was done, which was suggestive of infection. There were few cells, all were lymphocytes. Proteins were 80 mg%. She was treated with acyclovir. She became better. Her PCR for HSV was negative. She had convulsions at that time, and for that she was put on anticonvulsants, and she continued with that. She had some mental swelling, but there was nothing really dramatic at that time. She presented 4 months later with memory lapses, which was attributed to those high doses of anticonvulsant, but following which she had status. Because she had status, she had to be imaged again. And this is her scan 4 months later after that event. What she has is a large mass lesion in the left frontal lobe. This area was just showing that cortical swelling and signal abnormality. Even on retrospective analysis, there is this ghastly enhancement with the irregular peripheral nodular enhancement of the margins. There was intrasubstance enhancement as well. The lesion was extremely hyperfused. The spectroscopy shows typical choline with a lipid lactate peak telling you this is area of necrosis as well. So no mark for guessing. Histopathology was always going to be glioblastoma. This was not a metastasis, but because I did not know what was happening to those other brain lesions, I had requested my neurosurgeon to take biopsy from the adjacent brain parenchyma as well. And this non-enhancing area showed only inflammation, which was predominantly lymphocytes. So this was probably a case of autoimmune encephalitis, which was associated with tumor. Her anti-HU was positive. So here was probably a patient who had encephalitic type of presentation, which at the initial thought was probably viral, turned out to be a paraneoplastic, and her encephalitic presented earlier than the tumor, which was primary. We know that this happens with tumors like teratoma and in other parts of the brain, for example, thymoma, and patients present with autoimmune encephalitis before the primary tumors are diagnosed. But now we know that it can happen even in primary brain tumors. So thank you for your attention.
Yeah, Dr. Pangaria. Your mic is mute, sir. Please unmute yourself. Yeah.
Thank you, Dr. Atrey, for the wonderful lecture covering majority of the aspects of infections in the brain and showing some very, very interesting cases. I would now hand over to Dr. Vivek Lal. Dr. Vivek Lal, please.
Ashish, you made a weekend. Superb slides, superb lecture. You know,
Thank you,
I just have a question, Ashish. How commonly do you see an autoimmune encephalitis as a paraneoplastic manifestation of a glioma? I have never heard of it. I mean,
to be frank, I have the only case report in the literature apart from this case is credited to me, because I had seen this before. So this is a primary brain tumor with paraneoplastic encephalitis. An undescribed finding is the case report that I had titled and written. So apart from that, this is the third case that I have seen, the other being spinal cauda equina tumor, which was a ganglioneuroma. So I myself have seen these three cases.
oh, it's phenomenal. It's phenomenal. It's absolutely fantastic. And the other thing is, Ashish, there are many questions. I mean, you said that even if there is an enhancement in a tuberculoma, it does not mean that the tuberculoma is active. That's what you are implying?
It means it may not be that the tuberculoma is active.
And how do you determine when to stop treatment?
So what I mean to say is you cannot use imaging as a surrogate marker for the treatment stoppage decision, because we have seen it very often that this tuberculoma remain like this for years, as I showed you, and they are obviously not active, because if the patient is off tuberculoma, they should worsen at least if the disease is active, right, in 4 years' time.
That's right. They should. So it just means that you give them treatment for a year and a half. Have a look at have a look at the tuberculomas when we're going to call it quits for the ATT, and keep them on follow up. You don't prolong the treatment. You don't tailor the treatment vis-a-vis the vis-a-vis the findings.
Is what I would say, and I would add a caveat to that if you are doing this, and if you just do a CT scan as well as we did, if you find the lesions are calcified, the calcification almost always is a dystrophic calcification, which occurs most of the times in dead tissues. So once you see that almost all these granulomas are calcified, almost be sure that this is inactive tuberculomas, and you need not really prolong your treatment. So I always supplement it with a CT.
All right. And finally, you said, you said that was very typical of chikungunya. You showed that image where you're having those patchy diffusion weighted imaging findings.
Yes.
And you said that is chikungunya. You can't have that in, say, any other infection. That's very typical, you said.
No, it is seen in many other infections as well. You are absolutely right. I say in a patient who is suffering from arthralgia, rash, and fever, comes with this imaging findings, it is very typical of chikungunya.
It's very typical of chikungunya. We've ourselves seen, these findings in a few patients of dengue also.
Yes,
Dengue.
absolutely.
Dengue, I mean, as you correctly pointed out, dengue is the new kid now. In terms of neuroimaging, we've seen brainstem involvement, we've seen other changes with dengue, and we've also seen a lot of neuro-ophthalmology. We've seen macular involvement, and we've seen retinitis, and we've seen, a lot of involvement, especially of the deep brain structures with dengue encephalitis. That's right.
Absolutely, yeah. And I guess I had to answer that quiz which I started with.
Yes.
So I will just finish that because I don't see many people have. Three people have answered it correctly. The diagnosis, of course, the etiological agent is common. It is varicella. We know monovessel vasculitis is something which varicella commonly causes, especially in children. And we also know that the commonest cause of viral cerebralitis is post-chickenpox. So varicella is the answer to that first quiz.
Yes.
I think 5-6 people have answered it correctly.
Very correct, Ashish. And what was amazing is the florid cerebellar changes. Normally, we get to see a lot of post-infectious cerebralitis. Generally, the only change you get to see is swelling of the folia. You get to see a lot of swelling of the folia. The folia are not seen, they're obliterated. But what you have shown is a lot of diffusion restriction. You have shown enhancement, which actually is not that common. Am I right, Ashish? Am I right? It's not that common.
It is definitely not common. If you see leptomeningeal enhancement, as we saw in this case, you know that your confidence level of saying that this is likely to be cerebralitis is high, because in children, as you know, a similar finding of swollen cerebellar with signar abnormality could be seen in lead poisoning as well. They could have an identical presentation, but once you see that leptomeningeal enhancement, then you know that this is likely to be an infectious disease process.
Thank you. Over to Professor Chandrasekhar Meshram. Thank you. Sir.
Thank you, Sir Vivek, and thank you, Ashish, for excellent talk. Now, I would request Professor Mizusawa to introduce Professor Joe Berger.
Okay, I'd like to share the CV with you.
Yeah, it is there on the screen.
Oh, is that right?
Yeah, it is on the screen.
Okay. Just a moment. Okay, yeah. It's a great honor for me to introduce Professor Joseph Berger. He is a professor of neurology and associate chair of the multiple sclerosis division of the Department of Neurology, Parham School of Medicine, University of Pennsylvania. And he has also served as a chairman of the Department of Neurology at the University of Kentucky, I think. And he also received many awards, particularly from ANA, American Neurological Associations. And I think you all know him because he is a world well-known expert of the PML, HIV/AIDS, multiple sclerosis, and other inflammatory disorders of the brains. So I'd like to him to start his lectures. Please, Mr. Berger.
Well, thank you very much. My understanding was that there was a case presentation and I was supposed to discuss that particular case. Is that not the case, Chandra? Was there not a case presentation and I was supposed to discuss that particular case that was shared? The CPC?
Yes.
Yeah.
So is somebody going to present the CPC, or should I present the CPC?
Yeah, you present the CPC.
Oh, I'm going to present the CPC. Okay, all right. I thought maybe somebody else was going to. All right, well then I have to call up the CPC so that people can see. Has it been shared with other people, the CPC? Does everybody have the data?
Yeah, some people have.
Some people, but not everybody. Okay,
Yeah.
all right. You know, so then therefore give me a second and let me call up the CPC and we'll go from there. Sorry about that. I was a little confused. This is the story in my life these days. So this is a CPC. This is an 18-year-old man. The pathology discussant is going to be Dr. Radotra. And this man presented with headache for 30 days. He had right upper limb weakness and slurring of speech for 20 days. He had altered sensorium for 5 days and fever for 5 days. He was described as having a holocranial headache that was persistent throughout the day. It was continuous, severe, and associated with vomiting. He had right-sided hemiparesis that was acute in onset and gradually progressive. It started with slurring of the speech and right upper limb weakness and progressed over 10 days to involve the right leg. He also had altered sensorium. He didn't recognize relatives. He was not taking anything orally, and he had no verbal output. He had a fever for 5 days and no other systemic symptoms. His past medical history and family history was apparently non-contributory. He had no addictions, and on physical examination, he was drowsy with a Glasgow Coma scale of 10. His pulse was 64, his blood pressure 114/70. His respiratory rate was 24. He had pallor, edema. His chest was normal. His cardiovascular system was normal. His abdomen was normal, and his central nervous system showed that he was drowsy. He had neck rigidity. He had a right seventh nerve palsy, a central palsy, spasticity in all 4 limbs, equivocal plantar responses, and then the laboratory data was shared. There was nothing that was particularly helpful apart from the CSF, where there were 27 cells, 25 of which were lymphocytes. The glucose was 72, the protein 65, and an ADA was 2.17. And then it was repeated after 15 days, and it showed 20 cells, a glucose of 71, and a protein of 130. CT scan and MRI were provided, and in fact, maybe the best way to do this would be to show the scans to everybody. So what I'm going to do is put that on the screen. For some reason, I thought that this was going to be presented by somebody else. So let me share my screen. Hold on a second. So this was the CT scan obtained on this young man. I don't pretend to be a neuroradiologist, but obviously easily seen lesion in the left frontoparietal area, probably another one up here. And it's a little difficult to read, but the date on this was December 14th. And then this is a repeat that was obtained on December 23rd, so 9 days later. And you see this lesion here that has a peculiar appearance to it. And then this is the MRI from January 3rd. So maybe a week after that last CT scan, you see a lesion in the left occipital lobe. There's a lesion in the cerebellum and a lesion here in temporoparietal areas. This one is from January 3rd as well. It's almost got sort of a cerebriform appearance to it. There's some hemorrhage in these lesions. And then this scan is from January 3rd as well. Another scan, I'm sorry, yeah, also from January 3rd. And then this is the contrast pattern that one sees. And I'll read you, let me stop sharing for a second. I'll read the interpretation, if I can find it. Yeah, so the interpretation on the CT scan was the gyri in the left parietal lobe appeared bulky and hyperdense. There was a focal lesion measuring 3.1 by 2.9 centimeters surrounding white matter edema with post-contrast enhancement and central hypodensity. The impression of there was a similar lesion in the right frontal lobe and there was leptomeningeal enhancement. The impression was focal cerebritis with leptomeningitis. And then an MRI was done 15 days later, as I showed you, with multiple ill-defined heterogeneous intraaxial masses in the left cerebellum, bilateral frontoparietal areas, left temporal and left occipital lobes. There was evidence on SWI of hemorrhage, and there was mild enhancement seen with contrast. There was also moderate perilesional edema. And the course of the patient was the following. Following the evaluation and investigations, the consideration was that he either had septic emboli or TB meningitis. He was started on vancomycin and ceftriaxone. He was started on antituberculous therapy. And that was actually started outside the hospital before he was admitted to, I guess, the hospital that he ultimately ended up in. And he was given anti-edema measures, but he didn't improve. He ended up dying. And the cause of death was believed to be the raised intracranial pressure associated with multiple space-occupying lesions and questionable abscesses. So that was what was provided to me. And then I was asked to figure out what was the matter with this man and come up with a diagnosis. I will tell you that I may not get the diagnosis right. And this is what I tell the residents and fellows when they present a CPC. The value of these cases is really to see how somebody thinks through a problem. So what I'm going to do is think through the problem. I'm going to arrive at a diagnosis or diagnoses. And then my understanding is the pathologist is going to tell me whether I'm right or wrong. So what we have here, in essence, is a disease of about a month's duration, characterized initially by headache, followed by right-sided weakness and dysarthria of 20 days duration and fever for 5 days. The presence of headache and vomiting suggests the presence of increased intracranial pressure. One of the features that was not provided with the CSF analysis was opening pressure. And I find that one of the things that neurologists often fail to do, particularly neurologists in training, is to record opening pressure. I think if you're going to do a lumbar puncture, you should record opening pressure. It's enormously helpful. He was described as pale and afebrile. His physical examination was remarkable for the drowsiness, the right central seventh palsy, and spastic quadriparesis. And he had increased cells, but they weren't abundant. So he had 27 lymphocytes, a slight elevation in protein, and he had normal glucose. His glucose was 72. We weren't given a peripheral glucose, but the assumption is that it was normal. He also had a normal adenosine deaminase level. His liver function studies were elevated. The transaminases, the SGOT was 820 and the SGPT was 587. And he was uremic with leukocytosis in the hospital. There are bits of information that would have been very helpful for me in addition to what was provided, and that remain unknown. Now, I know because of the name of the patient on the MRI and the presenter that this is likely somebody from India. So at least I know the country of origin, and that's of some value. I'm not given much in the way of systemic symptoms. I presume there were none because they don't comment on it. They don't talk about travel history. They don't talk about unusual activities such as hunting or swimming. These are at least things that we would be thinking about here in the United States. And there's not very much on the physical examination that's very helpful. I'm not told whether he has papilledema that would support the contention that he has increased intracranial pressure. And we're given no results with respect to chest X-ray, chest CT scan, blood cultures, My presumption is if they were done, they were all negative. So I'm not going to ask anybody to provide those because they weren't in the data that was given to me. The imaging studies are helpful. They show a leptomeningitis. They show multiple intraparenchymal lesions with mild enhancement. They show patchy foci of restricted diffusion in areas of hemorrhage. And to me, there was a cerebriform appearance to some of these lesions, particularly on the MRI. So let's begin with what it probably isn't. And let's start with non-infectious etiologies. I mean, you just can't, obviously this is a discussion of neuroinfectious disease, but you cannot forget that this may not have anything to do with an infection whatsoever, similar to the case that was just presented, where the patient turned out to have a glioma and anti-Hu antibody. So could this be a malignancy, and what malignancy would it be? And I don't think it's very likely, but you can never rule that out. And lymphoma, some unusual neuroectodermal tumor would be in the differential. However, the progression of the disease is extremely rapid. He has a fever, and the MRI picture is really not consistent. An illness that we see with some regularity here is sarcoidosis. And neurosarcoidosis can do very unusual things. There are no systemic features that are described. So it would be isolated neurosarcoidosis, with the possible exception of the fact that his liver function studies were abnormal. And I have well over 30 patients in my practice with isolated neurologic sarcoidosis. Some of these individuals are individuals that do have liver function abnormalities, and on liver biopsy have sarcoid infiltration. Neurologic sarcoid affects at least 5 to 10% of patients that have sarcoidosis, and at autopsy, the number approaches 25%. As I said, it's not that unusual to have liver involvement, so maybe that's going on. And at times it can be explosive in onset, but this would be very unusual, this course, as would the fever and the MRI findings, particularly the diffusion restriction and the hemorrhage. So I don't think this is likely to be sarcoid. Could this be a CNS vasculitis, such as Wegener's, now known as granulomatosis with angiitis, or lupus? And we could certainly see with Wegener's dural thickening, leptomeningitis, parenchymal lesions, but he's not described as having sinusitis or pulmonary involvement. And again, the rapid course would be unusual. Now, he's a fairly young man. There's no family history. Another illness that came to mind is hemophagocytic lymphohistiocytosis, which may be familial. It can affect children. This patient is only 19 years old. It's secondary. It can be secondary to immune activation from infection or cancer. We will see it often with Epstein-Barr virus. It can give rise to headache, vomiting, focal neurologic features, and areas of multifocal inflammation on MRI. The protein's elevated. You could see a pleocytosis, but the pattern on the MRI is very unusual for it. So I don't think that's likely. Had I been managing this patient, I would have asked for serum ferritin levels, Epstein-Barr virus serologies, and CSF neopterin, which may be helpful. But this, after all, is a neuroinfectious disease discussion, and therefore, almost certainly it's going to be an infectious disease. And the way I like thinking about what the likelihood is and working through it is to start with the smallest infectious organisms and work my way up to the largest and see if I can arrive at the diagnosis. It's definitely not a prion disease, that we can all agree on. And this doesn't look like a viral disease. Amongst the bacteria, I think TB is a very good thought. You know, one of the things that I often teach the residents is that when you see something unusual, it is typically an unusual manifestation of a common disease rather than a common manifestation of an unusual disease. And TB is extraordinarily common in India, so could this simply be TB? Arguing against the diagnosis is the normal chest examination, presumably a normal chest X-ray, although I wasn't given that data. The MRI findings would be unusual. The CSF glucose was normal. The ADA was normal. That would be unusual. And he'd been started on antituberculous therapy and appears not to have been responding. Another diagnosis that was considered in the bacterial category was septic embolization, presumably from endocarditis. However, on clinical examination, there's no evidence of endocarditis. The results of blood cultures and echocardiograms were not provided. The MRI would be very uncharacteristic. Typically, what you see are strokes, emboli at the gray-white junction, mycotic aneurysms with subarachnoid hemorrhage. And furthermore, he was treated with a fairly broad-spectrum antibiotic regimen and continued to worsen. There are other infections that I considered but didn't think were very likely, things like Brucella, Listeria, and syphilis. So moving up the scale, let's go to fungi. And I think that fungi are unlikely for two reasons. One, regardless of the fungus, although a true hyphae is something that would be a consideration, like an aspergillus. I don't think the MRI pattern fits, and I think that the CSF glucose being normal would be unusual. It would have been helpful to have a CSF beta D glucan. That I would have liked to have seen cryptococcal antigen in blood and CSF. I'd like to have seen fungal cultures. However, my suspicion isn't high enough to consider that fungal meningitis with intraparenchymal abscess is likely. So that takes us to parasites. And we don't see a lot of parasites in my neck of the woods, so to speak. One possibility are cestodes. Could this be Echinococcus, hydatid cyst? This really doesn't look like hydatid cyst, but in the interest of being complete, you'd have to think about it. It really doesn't fit the clinical or radiographic picture. You typically see cyst on MRIs. Tapeworms are a possibility, things like sporaginosis, such as Loa loa, which typically result in punctate calcified calcospheres within the parasite and hypodense white matter lesions with variable enhancement. So I don't think that's likely. We do see a fair amount of toxoplasmosis. I don't think this is toxoplasmosis. My experience is largely in the AIDS population, where when I was practicing at the University of Miami in the early days of the HIV epidemic, where toxoplasmosis was the most common brain lesion that we saw amongst AIDS patients. This doesn't have the appearance of CNS toxo. Furthermore, there's no evidence that he's immunosuppressed, though I would have liked to have known his HIV status. And I was very intrigued by a case presented a couple months ago of an HIV-infected child that also had SSPE at this meeting. You can never throw out HIV, so regardless of the age, I would like to know. Trematodes like schistosomiasis are a possibility, but typically they give rise to single or multiple hyperdense lesions that are surrounded by edema with variable contrast enhancement, and they have this arborized appearance on MRI. So that takes me to amoeba, and I think that this is likely to be an amoebiasis. So there are really two forms. There's the primary amoebic meningoencephalitis, Negliria fowleri, which we do see in the United States. We see it in, often in children that end up jumping into lakes, freshwater lakes here, or young adults. And it's usually stagnant fresh water that contains the organism in the warm summer months. And this is a disease that's rapidly fatally progressive. So death usually ensues within a few days. The MRIs show edema with lesions that are most notable in the posterior fossa and the brainstem. This man's illness was clearly too slowly progressive, and the MRI is not consistent with that diagnosis. So that leads me to granulomatous amoebic meningoencephalitis. And there are such organisms as Acanthamoeba histolytica and Balamuthia mandrillaris. They're present in the soil around the world as well as in fresh water. They're found in, the Acanthamoeba is found in water fountains and in neti pots. That's where we're seeing it these days. People that are using these neti pots to improve their respiratory clearance. Acanthamoeba is uncommon in immunocompetent hosts, but Balamuthia is seen in immunocompetent and immunocompromised patients about in equal numbers. It generally spreads from keratitis, from skin infections, or from pulmonary foci, and the encephalitis generally evolves over weeks to months. The contrast enhancement head CT scan of granulomatous amoebic meningoencephalitis, shows ring-enhancing lesions. The MRI typically shows multifocal parenchymal lesions with diffusion restriction in the abscess cavity. You can see edema and hemorrhage, and the locations include diencephalon, thalamus, posterior fossa structure. So my sense is that the MRI and the CT scans are really quite helpful here. They're certainly consistent with the granulomatous amoebic meningitis. One sees an associated necrotizing angiitis with chronic granulomatous reaction containing multinucleated giant cells with trophocytes and cysts. And there's a terrific review in the American Journal of Neurology by Singh and Kakbar entitled Amoebic Meningoencephalitis, Spectrum of Imaging Findings. So my belief is that what we have here is likely to be, and I may be wrong about this, but because I have no idea, is likely to be a granulomatous amoebic meningoencephalitis that led to death. I guess we'll find out when the pathologist presents the case.
Thank you very much, Professor Berger. Okay, so Professor Meshram, is there any comment or the additional information about clinical features? No?
No, I think
We can wait pathology?
no, we'll have the comments from the panelist and the audience, and then we'll go to pathology.
Okay.
I think
Yeah.
Professor Berger, I think, can I say something? It's been a brilliant discussion. Professor Pangadia, what's your opinion? I thought it's an Indian discussing infections. Fantastic.
It was very,
Fantastic.
and I think it was a very broad spectrum kind of analysis.
Yeah.
But I was wondering, I think I would possibly go with amoebic as one of the possibilities. To my mind, glioma or sarcoid is very unlikely. I would put my money on two more diagnoses. One is an atypical form of lymphoma, which is known to present rapidly. And the other is, of course, malignant form of tumefactive demyelination, because these are seen in younger age group. So I would put actually three possibilities. One, agree with amoebic encephalitis as one of the possibilities, because we have seen two cases of amoebic encephalitis, toxic encephalitis in PGI series, but I think both of them had relatively shorter history. But two similar cases, one was lymphoma, which presented like meningitis and had multiple lesions with hemorrhagic components. That in a younger age is likely, is one of the possibilities. And the other, of course, is tumefactive, younger age, malignant form of demyelination.
I would just say that he was put on steroids. Firstly, I don't think that the MRI looks like tumefactive MS. And he was put on steroids, and typically those people respond very well to, I don't know what dose of steroids he's put on, but they usually respond to high dose steroids. The other thing is that the lymphoma patients often respond to high dose steroids as well. And this guy has an inexorable course to death. So despite the treatment, it wasn't working. And therefore I sort of discounted those. Plus, I thought that this was going to be an infectious disease.
One of such cases. So I thought this could be one of the possibilities where it is rapidly, of course, I agree that steroids could have given him some relief. So, but lymphoma and amoebic, and of course the third I have already given. So any more from the audience? I think it would be interesting to have more options before we ask the pathologist to finally tell us.
Yeah, we can ask comments from Professor Raj Shakir or Professor Griswold or Christina Mara. We have a lot of panel. Hadi Manji, Professor Singhal.
Well, I'm really struck by the transaminitis. Didn't you say that is his LFTs were in the 500 range.
Yeah, actually, they were higher. They were in the 800 range, and that was the only thing that was provided in terms. So I don't know whether they came down. I'm not sure whether they were related to a drug that he might have received, and I wasn't given other liver function studies to determine, to help in trying to figure out what was going on with him. That was one thing that struck me as well, and I wasn't sure how to put it together, and that's why sarcoid became a bit of an issue. I'm unaware, and maybe it's just because I don't know. I'm unaware of an association of a hepatitis with amoebiasis, but I imagine it occurs.
I was thinking about whether you could have primary HSV, so that can give you a really bad hepatitis. And the other thing would be hepatitis A, which I think hepatitis A is the one that's an enterovirus.
Yeah, the only problem with that is the MRIs didn't look anything like either of those.
Yeah, I agree. Why we need a pathologist.
Right.
Can we know his HIV status, Vivek?
Negative. HIV was negative. Done twice, HIV was negative. I'm sorry it was not provided, Professor Berger. I'm really sorry. It was negative.
It's okay.
So let's hear.
Hi, it's Hadi Manji here. I was just wondering about whether there was an underlying immune deficiency state, because the lack of fever was never a major issue in terms of his presentation of an infectious disorder, and neither was a CSF. And I must say, when I first read the outline, I did wonder about toxo or something like that, somebody who's immunosuppressed, but he's HIV negative, but maybe there are other reasons in terms of immune system deficiency, which may predispose him to an immune deficiency infectious disease, really. That was my first impression, but it was a great discussion there.
Ashish, would you like to make some comments on the imaging?
I think imaging wise, there is clearly leptomeningitis, which we are all sure, and Professor Joberger has almost described all the findings on MR, how I would say. I feel there are a few hemorrhagic changes from what images I remember, and I saw that when he was projecting them, there are hemorrhagic changes in those lesions, and the lesions in 2 MRs have grown with increase in mass effect and appearance of a new lesion in the left cerebellum, which was not seen on the initial MR, is what I recollect from those images. So imaging wise, I feel I don't see it to be a signature pattern of any particular infection. I don't think I can give an etiological presuming it is an infectious disease CPC. Otherwise, of course, granulomatous angiitis is something which needs to be considered, because it will have such inflammation and could have associated diffusion restriction and hemorrhage. And other non-inflammatory pseudotumor, as we call them, because it is involving more than one brain structure. It is involving meninges, it is involving gray matter, and then it is involving white matter. So it is kind of transplane disease process. So plasma cell inflammatory disease process is something which is also high on my cards, because that can look like almost any infection. Aggressive infection, I mean.
Yeah, I have a question. I mean, the type of enhancement is very typical, and it's slightly different. It's not the way you get. It's not a ring enhancing lesion or a densely enhancing lesion. I think this kind of enhancement is more like a gyral enhancement, and which is probably, I think, the first thing that we would think of is amoebic meningoencephalitis, with these mass lesions. So I think Dr. Berger is definitely hit the nail on the head by the imaging pattern is quite typical, I think so.
Yeah. Any comments? Any other comments from the panelists?
Yeah, but the only thing is that twice the CSF sugar was normal. Professor Berger?
Well, I don't think that bothers me with amoebic meningoencephalitis. That's not that I have any experience with it, but my understanding is it can be. So that doesn't bother me as much. I mean, it tells me that it probably isn't bacterial or fungal.
Right. All right. Great discussion, nevertheless. I think we can go on to the pathology now, Professor Adotra.
Yeah, if there are no other comments from other faculty or panelists, so then we can move on to pathology.
Okay, so
Vivek?
Yes, sir.
Please introduce Professor Darotra.
Oh, well, yeah. Professor Adotra, yes, I'm sorry. Professor Adotra is professor and he's chair of the Department of Pathology at our institute, that is Postgraduate Institute of Medical Education and Research, Chandigarh. That is where we are at the moment. And he also is a neuropathologist. He trained in Ireland and he is Dean of the Indian College of Pathologists till date. And he was awarded the Commonwealth Fellowship at Belfast in UK. He's got more than 370 peer-reviewed publications. All that is fine. But the important thing is he's the most feared pathologist by we clinicians. Because whenever he does a CPC, he takes us for a ride, So I think that's the biggest feather in his cap. His CPCs are absolutely fantastic. They're fantastic. And over to you, Professor Adotra, to tell us what this patient had.
Thank you. I was just trying to share.
You muted yourself.
Professor Adotra, you're mute, sir. Yeah.
And can you hear me?
Yes. Yeah.
We can hear you.
But you can't see the screen.
Yeah.
Not yet.
So I have my screen there, but I think
Screen, you share the screen.
new share probably.
Share screen. You click on the share screen button down below.
Yeah.
No, I think that the screen is shared. I think there we go.
Yeah, it is come now.
Yeah.
So now I think I'll. So thank you very much for the asking me to be associated with you people, and I think
Professor Rarutra, just put it on the slideshow. It is
okay. Slideshow. No, but I think I have to do this. No?
Yeah. That's fine.
So it has gone. Okay, so just thank you very much, and I enjoyed the clinical discussion, and I think I would agree with Dr. Vivek Lal and Dr. Gagandeep that Professor Berger has hit the nail on the head, and it was pleasure listening to him. So this was about a young man who died in our hospital, and an autopsy was done, but it was limited to brain. So I won't be able to show the pathology of the liver. We generally do complete autopsies, but in this case, it was only limited to brain. The consent was only for brain. The brain weighed 1,352 grams, and here I'm showing you the inferior surface as well as the superior surface. You see the inferior surface, it is clean. There is no exudate. Olfactory bulb, olfactory tracts, optic nerve, and the oculomotor nerves, they are all visible. Interpeduncular fossa structures are seen. I've removed here the vascular tree, but the blood vessels at the circle of Willis were normal in caliber, and they did not show any embolus, thrombus, anything. On the superior surface, you can see the brain is quite edematous. And we can see some focal areas of purulent exudate on the right side. I have labeled actually right and left so that there is no confusion. Because we are used to seeing the brain corneal slices right on the right side and left on the left side, unlike MRI images. So that's why I have labeled them. So we have some exudate over the frontoparietal areas, and okay, so next. So then the brain was cut into corneal slices. That's the usual routine we do. And here some of the slices are displayed in on the right half of the screen. And sorry. And you can see that terminally there was extensive involvement of the brain on both sides. But I think one thing which you can appreciate is that the involvement on the right side was more in the frontal areas compared to the left side, which also involved the parietal or occipital areas. And I think there is a good clinical radiological correlation. I will show you one in the next slide also. But the lesions were in the form of hemorrhagic necrosis. They were in the parasagittal areas, in the frontal lobes. And this is from anterior to the posterior, I have mentioned with the arrows. And you could see that this large lesion on the right side was about 6 to 7 centimeters in its anterior-posterior dimension. It involved the superior frontal gyrus and the middle frontal gyrus. Part of the corpus callosum was also involved anteriorly, and both the cingulate gyri are involved here. And you see posteriorly, the lesion was quite extensive on the left side, and you could see the involvement of the parietal lobes and the temporal lobe. Superior temporal gyrus is completely gone, and it is abutting to the middle temporal gyrus. And there were many small lesions which were evolving. And here you can see a small lesion, the hippocampus, on the right side. So as Dr. Ashish Atrey has mentioned that they rapidly progressed, and these are the pictures towards the terminal sites. So some of the lesions might have been appeared late after the after the MRI. So here I'm showing you a little higher close-up of one of these slices, and shows gray matter involvement as well as the white matter involvement. Overlying meningeal purulent exudate was seen. This was a lesion about 1 centimeter in diameter in the left cerebellar hemisphere. And the next slide I'm showing you that, as I said, that there is a good correlation. So you can see on the right side, the lesion in the parasagittal area, which is going to involve the corpus callosum and the cingulate gyrus. On the left side, there was that gyriform enhancement, which is very closely mimicking here. So brainstem, midbrain pons were uninvolved, and so were on the right cerebellar hemisphere folia. So, okay, so multiple sections were taken from the involved areas, and this is one of the sections that I'm showing you to say that there was significant amount of leptomeningitis, and you see the entire cortex is really almost gone. It is involved by this inflammatory component. I'll show you the close-up of these. And this is close-up of this particular area of the leptomeninges. There are a lot of these macrophages, plenty of these lymphocytes, and it's lacking the neutrophilic response, at least in the meninges. Occasional multinuclear giant cells were also noticed. And you see the inflammation is going on to involve the superficial cortex in this slide. A section has been taken from this lesion, which also included the left side of the superior frontal gyrus, and it is shown here and the low magnification. And you see close up, there was significant amount of vasculitis, or I would say angiitis. This is a almost medium-sized meningeal artery, and you see the periarteritis is there. The blood vessel wall is necrotic. There are these small abscesses within the media, and there is early thrombus formation. In the other sequential sections, there was thrombosis also. And the meninges are, again, you see these are fully filled with this inflammatory exudate. The adjacent areas in the deep inside the brain, they were showing a lot of necrosis, so plenty of necrosis, occasional giant cells. There were almost actually sheets and sheets of macrophages, and some collections like this. Perivascular inflammation or angiocentric inflammation was noted, and the more you noted that there was a lot of choreorexis, nuclear debris, and fibrin thrombi, that is capillaries showing fibrinoid necrosis was there, some giant cells, and a few plasma cells, and more you saw, you found these things. And here I'm showing you that there was neutrophilic as well as histocytic response. But you notice that in addition to these macrophages, you started looking at these larger structures. Some of them were degenerated, others were intact, and a closer look of some of the better areas showed perivascular collection of these trophocytes, and within the parenchyma as well as in the perivascular location. And in some areas, you could also see the cysts of these amoeba. So they were mostly in clusters and species. PES stain showed their granular eosinophilic cytoplasm was highlighted, and you see these, they have small nucleus, vacuolated cytoplasm, and sometimes they had prominent nucleolus. So this is how you, I mean, pathologists may find it difficult to see these structures. The reason is that this particular pathology is full of macrophages, so it is very difficult to really sometimes find. In this case, it is okay, easy perivascular trophocytes can be seen, but otherwise, sometimes it may be difficult. But there are points which I would like to highlight here, that the trophocytes, they are usually seen in the clusters, particularly around blood vessels. They have smaller nucleus, something like this, and they are surrounded by a halo. Whereas it may not be true for this. Sometimes this hemophagocytosis, RBC within the cytoplasm of the trophocyte, can be demonstrated by special stain like mesenterichrome stain or PTAH, phosphotungsten hematoxylin. And this is, we tried electron microscopy also, and this is a samothin section, and which shows a trophocyte with a small nucleus and a very prominent nucleolus and granular cytoplasm. EM pictures I have misplaced somewhere. I remember that time I had not done it, but later we did it, but they are not there. We used immunohistochemical stain CD68, which labels macrophages, and you can see that most of the macrophages were labeled, but compared to this, the trophocytes were not labeled. They will be labeled if you use the antibody against these trophocytes. So these antibodies are available. We don't have them because these are very rare cases that we get. So, but we have other measures to confirm this. So trophocytes were not labeled, whereas the CD68 labeled the macrophages. So these were trophocytes. Adjacent area showed a lot of necrosis and infarction because of the thrombosis of the vessels. And this is the gray matter where it is very recent infarct. And this tissue from the lesions was submitted for PCR, and it was negative for, actually it is difficult to sometimes make a differentiation histologically between acanthamoeba and Balamuthia. So rather impossible, except from differences in the size of the amoeba. And cysts are very uncommon in acanthamoeba, whereas they are commonly seen in Balamuthia. So we sent some tissues to the parasitology, And this is the PCR findings that it was a PCR targeting the mitochondrial DNA. The Balamuthia was done. The lane 1 is the ladder, and lane 2 is here the DNA from a sample of positive sample of Balamuthia. This was a positive sample for Acanthamoeba. And the 5 and 6 lanes are from the patient itself. So they showed this DNA 1075 base pair positivity, which is quite typical for Balamuthia. Further, actually, we had also followed it with the sequencing, and it showed, this case showed 100% homology with Balamuthia mandrillaris. And therefore, the autopsy diagnosis in this case would be Balamuthia mandrillaris meningoencephalitis. Thank you.
Terrific, thank you.
Yes, any questions that I will be happy to take.
Question.
This is Rad here. Can I ask a question?
Yes,
First, Joe Berger, wonderful discussion. I loved it. And it's, I like this small to big, and you got to the big, which is very, the question to the pathologist is this: if a brain and meningeal biopsy was done from this lesion, the right frontal one, would that give you the diagnosis, or the leptomeninges will not be sufficient, or the biopsy will need to go deeper? Or what would you like to see if a biopsy was done, say, on day 15 of the illness? This 18-year-old lived for 30 days.
Yes, please.
What would you like the surgeon? What would you tell him? Where does he get the biopsy, and what should he get?
These the biopsy is the only answer in these cases, and the biopsy from the leptomeninges would not give the answer, because these trophocytes cannot be seen there. So biopsy has to be from the lesion itself, deeper enough. We had been we have some cases which we diagnosed on surgical biopsies. I remember first many years ago, 20 years back, we got a frozen section and we missed it. We didn't say that this was Acanthamoeba encephalitis. It has been published as Acanthamoeba. I don't know, that time we didn't have PCR, but it was only on morphology. So you can, now these days, of course, we have immunofluorescence, of course, PCR, but biopsy from the deeper areas, from the necrotic areas is important, not the meningeal. And of course, we recently also we have diagnosed Balamuthia in one case. Unfortunately, he was diagnosed ante-mortem, but he succumbed to his illness, and autopsy was not performed in that. But molecular diagnosis was obtained from the biopsy. Then there are other cases like Acanthamoeba. We have some experience in that, patients of leukemia. And frozen section was sent to us, which one of my colleagues reported it to be cryptococcosis. They said, okay, it's showing cryptococcus. But, you know, because she saw those rounded structures and they were in clusters actually. So when I came after a meeting and I looked at, I thought it is not cryptococcus, because cryptococcus cannot be that big, and cryptococci are usually very translucent. So we processed it very quickly, and then we followed it up with the microbiologist. It turned out to be Acanthamoeba, and that has also been published. So these are difficult things, and they, as has been discussed by Professor Berger, although they say that it's a subacute or chronic course, but in our experience, well, in weeks probably. And the first case that I saw of Naegleria was in 1991, and that patient died very quickly. And autopsy was done, but that time I had not seen any case of Naegleria, but that died within 3-4 days. So deeper biopsy, not the meningeal biopsy, would be helpful.
Yeah. And
May I ask Dr. Radote a question?
Sorry, I just have to come back if I may. Sorry to interrupt. would that explain the reason why the CSF was not that active? Because the organisms are deep and the leptomeningeals are just reactive, and therefore the reaction in the CSF has not been 20 cells, 27 cells, has not been fulminant for us to see. Is that the pathology of it? Is it just a parenchymal with little leptomeningeal involvement? Is that what you're telling us?
Yes, the one thing is that the leptomeningitis is focal. It is overlying it is showing exudate only in the areas where the lesions are. It is not showing any diffuse leptomeningitis. That is one. But the thing is, what I'm showing you is at the, say, 21 days after CSF was done. So that time, maybe the lesions were not really into the leptomeninges. Otherwise, there is no other way. I'm sure that towards the terminal part, there must have been a lot of cells in the CSF, and I'm sure there would have been in hundreds, so which have not been picked up. So either the timing, and the other thing is because these lesions progress very fast, and something which I've shown you is towards the end. That is what I was earlier also saying. Plus, it is a patchy meningitis. It is not a diffuse meningitis.
So I would just like to ask Dr. Radocha a couple questions. If you had expected this to be, if it was in the differential at the time the child presented, and you looked at the spinal fluid, you had the spinal fluid in hand, could you identify the organism in the spinal fluid or identify the antigen or do a PCR for Bowmutia to detect it?
PCR is certainly, because this antigen is not, this antigen is also taken up by the macrophages, because of the breakdown and all. There is one paper in human pathology where they had evaluated 18 patients of amoebic encephalitis, where I think 11 were of Balamuthia type, and 4 and 3. 11 were Balamuthia, 4 were Naegleria, and 3. So they had shown in that I think about 2004 it had appeared that the macrophages also showed the presence of that immunofluorescence positivity when they use the specific antibodies for these 3 organisms. So I am sure the macrophages would also have the antigen, and therefore PCR maybe of the CSF should be able to pick up. But otherwise, CSF examination will not show anything. I mean,
Thank you.
histology-wise or cytology-wise.
Right.
The only thing is that, that one has to be very aggressive in this thing, and suspicion is one of the important things that one has to keep it in mind. So in our institute, I think because we have been, we have shown in CPCs, plus we have missed it sometimes, and so there is always a suspicion. So our clinicians are always suspicious, and they do, I think whenever there is a case like this, they keep this as a differential diagnosis. Because we have,
and this is extremely rare in the United States. So why do you think it's more common in your area than it is in North America?
Well, I don't know, because, and these are the patients who are apparently immunocompetent that I'm talking about. The
Right.
one Canthamoeba that we saw, where we got the frozen section, and the neurosurgeon was very aggressive neurosurgeon. So he sent us the material, and that was a case of leukemia. And these lesions, they progressed. He was on, I think he was in remission, and then he got this infection, and progressed in 2-3 weeks time. And so I think immunosuppression is not the only thing. We are getting in immunocompetent. Well, I think this organism is picked up from the soil. So we might have farmer community in Punjab, we have farmer community, and so on. So maybe people are picking up. We don't know how many of them die, because not autopsies are not done in all cases. So these are the rare cases that we have picked up on autopsy, but we don't know. and particularly when it comes to our hospital. But because it comes from the soil, so maybe I don't have any data on say culture from the soils, etc., etc. Nobody has done. Our parasitology department, they had also published one case of acanthamoeba, in which I am not involved. But these are very rare cases. From our department in 2007, I believe there was a publication of few cases, whatever we had collected. But that time we were not sure. They were published as acanthamoeba encephalitis. But I'm not sure really whether they were Balamuthi also or not.
I see.
We have in our institute, I think in the last 3 years, we've seen just 4 patients in our department, and none of the 4 made it. In fact, this case, when now I can share all this now that the diagnosis has been made, when we saw the imaging and the way the patient was going down, as Professor Berger correctly pointed out, inexorably he was going down the cliff. We strongly suspected amoebic meningoencephalitis. Unfortunately, before we could get him, he couldn't make it, and it was proven on autopsy. We suspected it as the prime possibility and the first possibility when we saw the imaging and we saw that he's not responding to anti-tubercular therapy. And we thought of this, and it was proven on autopsy. And that's the story. It was very unfortunate. And the imaging also, as Professor Berger, you pointed out, and the others pointed out, looked more towards this possibility. I mean, it kind of biased us towards this possibility. As you correctly pointed out, Professor Berger, there were no basal exudates, and the CSF sugar was persistently normal. So that would certainly be a strong point which would militate against tuberculosis and fungus. And so we kind of looked at this as a strong possibility, and it was proven on autopsy. But this
Vivek, when you thought of this as a strong possibility,
yes,
could you have started some anti-amoebic therapy?
I tell you, sir, I mean, that's the cross of David which I have on my heart now. I don't know whether it was, whether it would have made a difference or not. I'm not defending myself, but I think we should have when we thought of that.
And second, one more comment for Dr. Berger.
Sir?
When I was reviewing CNS infections which are transmitted by solid organ and hematopoietic tissue transplants, there have been 2 cases of Balamuthia mandralis transmitted via solid organ transplant from America.
Right. It's funny, I'm aware of that because I was looking for whether the abnormal liver function studies could be associated with amoeba. I'm sure they can be, but if you Google hepatitis and Balamuthia, those cases of transmission from solid organ transplant from 2014 come up. I just did that because I was curious.
Professor Katrak, I just saw the protocol. I think he was with us for just 2 weeks. I mean, he came with his history, and he was with us for not more than 2 weeks. So that's how it is. That's why we probably, if he had stayed a little longer, probably we would have, but I'm not defending what we did do.
What is the therapy? Pardon my ignorance. What is the therapy for Balamuthia?
I don't know whether the
I have to look it up myself.
Yeah.
But I have read this clethromycin and fluconazole and so on. One patient, I think there was one patient who I had read survived, and he was okay for 6 months till they had published that case. So in immunocompetent patient, so that also was picked up by the open biopsy which they did.
Does metronidazole have any effect?
No, not in Balamuthia, sir. Not in this entity, sir.
At the liver end?
Beg your pardon, sir?
For the hepatitis. Maybe it does not penetrate the blood-brain barrier.
Sir? I feel that the hepatitis may have been related to the anti-tubercular therapy which this patient received, as Professor Berger had pointed out. That transaminitis may well have been because of the drugs that this patient got. Of course, we can never say we are right or wrong because we don't have the liver with us to see what happened there.
Yeah, actually, one point to that is that his SGOT was 820 and his SGPT was 587, which suggests that this probably is a toxic hepatitis as opposed to an infectious hepatitis.
I was going to say that our own experience is that it is basically this level of enzymes in liver. We have a lot of cases of infections, and so toxic hepatitis or septicemic hepatitis, it can go up to that, and that is, and we don't find any specific thing, but only thing is we find some neutrophils infiltrating the sinusoids and so on. So that may explain. Because towards the end, the leukocytosis was also there. So I think septicemia.
May I ask a question? This is a beautiful case, and also the histology is wonderful. May I just ask, as a completely ignorant of amoebial infection, are there other organs infected too? And one question in particular, are there other body fluids like the vitreous fluid or peritoneal fluid affected too by the amoebiasis, or is this just restricted to the brain parenchyma?
Well, from my reading, I saw that you can get a keratitis with it. So obviously the eye can be infected and the skin can be infected with Bowelmuthia as well. So, and it's thought that it gets into the brain from those sites. So I think as a soil organism, that's probably what happens, that it contaminates the skin or the eye and the infection starts there.
Okay, interesting. Thank you.
I think there are, it is known to, particularly Bowelmuthia is known to affect kidneys, liver. It can, and of course, as Professor Burgess said, skin and respiratory infection is likely from the soil. But the two cases that we, one of this and the other one which also died, but autopsy was not done, that we have published is that one of them only brain, in this case only brain was removed. In the other case, there was no clinical involvement also. Both the cases did not show, and particularly the other one did not show any involvement of kidney, liver, and lungs. So, but these are likely to be involved. These are known to be, they have been reported to be involved.
Thank you.
In addition to brain.
Professor Pangadia, sir, would you like to say something, sir?
Yeah, actually trying to look into the treatment because even if one of the things actually I just went through is keratitis could be associated with encephalitis. So I wonder if that is a clue to the diagnosis in rapidly developing meningoencephalitis. And then obviously we need to know the treatment even if we diagnose. But it was very interesting, and I must compliment Dr. Joy Berger, and it was wonderful discussion, and thank the pathologist, and thank Dr. Meshram ultimately, because who organized all this. So we have all been enlightened. It was wonderful discussion, and compliments to all the participants and listeners.
And I would like to say something. I would like to say that I am really very happy to be associated with you people. I didn't know whether I was supposed to be right from the beginning or not, but I logged in and I was not sure whether I was wondering that I may find some difficulty. So I logged in to see that, okay, I'm going. And then I attended Dr. Atrey's Ashish lecture. It was wonderful. I really learned quite a lot. And thank you so much, Professor Berger. I'm very happy that I was part of the case presentation with you. Thank you all.
Thank you.
Before we go, may I read the line of treatment? It says amphotericin B 1.5 milligram per kg per day, intravenous in 2 divided doses for 3 days, then 1 milligram per kg per day for 11 days. Amphotericin B 1.5 milligram intrathecally daily for 2 days. Then 1 milligram per day every 48 hours for next 8 days. And azithromycin 10 milligram per kg per day either intravenous or oral for 28 days. So it's a 4 weeks total course, which I just found on Google.
You cannot give amphotericin B on a suspicion, but at least azithromycin can be started.
Yeah. But if the man is dying, obviously you
I know.
take.
But Ashok, it's intrathecal amphotericin.
No, but the recommendation.
You require a lot of guts to do that.
That's right. That's right. It's the patient came with a very fulminant illness. I think he didn't give us time. I mean, you see, it's okay. We discussed.
No.
We just had a week or 10 days with the patient. Everything had been done before he came.
I asked that question as a learning question.
No, I appreciate that, sir. I
I
appreciate
didn't
that.
ask
It's
it
been a fantastic exercise.
If everybody agrees that it was a very fulminant illness.
Yes, yes. That's right. And the best part is, I don't know where's this. This is autopsy is a procedure where the dead teach the living. It's a procedure where the dead teach the living. And that's it. That's what this case has done for us. Thank you so much, everyone, sir. Over to you, Professor Meshram, sir.
Yeah, thank you very much. I must congratulate Professor Joe Berger for excellent presentation and Professor Radutra for showing us a great pathology, and Dr. Ashish Atrey for excellent talk, and Dr. Ashok Pangaria, Dr. Vivek Lal, and Professor Mizusawa for being with us, and as well as Professor Singhal, Professor Katrak, Professor Raj Shakir, Professor Gisold, Professor Hadi Manji, and Stephen Lewis. And I just missed few bits because I was not able to see Joe Berger. So I contacted Steve and he helped me out, and everyone else, Christina. So thank you very much. I think we had a great session, and we'll see again next Saturday, same time. Thank you very much for being with us.
Good night.
Thanks. Bye now.
Good evening, good morning, and good night.
Bye-bye.
Safe, everyone.